is the George gauge. Okay. So I know the lighting is a little dim. So can you just have a quick look at this gauge? So in the gauge that I'm just passing around, scan ready. Okay. So this is how it looks when you have the scan, once you do the scan. Okay, I just process this and you can see how it is. And then I can just connect my laptop to show you the gauge. So as of now, just look at the markings on that gauge that is being passed around.
The millimeter markings which can be.
Yes, there is 0, there is 10 on both sides. Okay, so that is the main thing that I want you to see. 0 and 10 on both sides. So my plane is relatively regular. You can ignore my amalgam fillings, but the plane is relatively regular, right? But it's not in all patients that you will see this. In some patients it will be a little more because there could be supraerupted molars. Okay, so this is how generally it looks. Is this clear? So this is how the scan is going to look once we complete.
It's more like an implant scan body which is not visible in the scan. This is scan body that we are going to use for the picture.
Yes. Okay, can we just connect my please? I'll do the single sided and I'll explain. What is our time? 1:3. Okay. So 1:15 and then questions. Till 1:30 and then 1:30. It's not very boring, no? So, yeah.
That's nothing.
Software is eliminating that form.
Yes. In one scanner, today, in all the scanners that I've seen the scans, iTro's Lumina, that newest scanner, in that it doesn't eliminate this perfectly. Because the FOV is so big. So that we gently cut out this thing. But in all other scanners, normally it cuts out the binder. Okay, so have all of you had a look? That is wise, sir. You're using the torch. As I think everyone else has excellent eyesight. Lighting is pretty dim here.
Say again, switch on the lights.
Huh? No, we've got a few slides. So.
If standard advice adjustment is okay, but still somebody wants more than
Yes, so I'll come to that after this. This is our starting point. That's why I'm saying this is not our final position. Where is the public now?
Speaker is on top. Yeah.
Because otherwise it's not supposed to hold. So has everyone just seen the gauge? There are two gauges. Okay, so one, the blue gauge that you saw is what is called the George gauge. It's nothing to do with me. It's from the US. Okay, incidentally, both I have the same name. And the one in pink is a printed gauge. It's a printed protrusion gauge. It's printed from biocompatible resin. It's basically printed from denture resin. So now you can use either of these gauges to use this single-sided fork. Now the double-sided is clear. You all know how when we use the double-sided. But if a patient cannot bring the jaw to edge, if the patient cannot tolerate class 2, so you can't record the jaw at edge to edge. Now these bands that you see on the appliance, there are different sizes of bands. So there are even bands that take the jaw a little back, that is long bands, but that's only 2 mm. Okay? So it's always best to be on the safer side. If you feel that the patient cannot tolerate edge to edge, you need to take a lesser protrusion. Otherwise the patient will not be able to tolerate the appliance. So for that, you need to use this single side. Okay? And along with a protrusion gauge. Now you saw this. No. Please, back here. So you saw these markings, right? Now for the George gauge, ideally the blue insert has to be changed for every patient. It's disposable. The other one is biomedical resin, so we don't have to change that insert. So we have markings from 0 to 10 on either side. Okay. So what we do is we don't have to touch that lower screw. We just remove the upper screw. In the printed gauge, there's only one screw, so there's less confusion. Okay? So,
You want this?
no. I'll just take the pink one. Sorry. Thank you. So we loosen the screw and insert the bifork at 0. So I insert it at 0. So if you can see here, the fork is inserted to 0 and I tighten it. So when I tighten it, I get a double-sided, something similar to double-sided. 2 slots, something like the double-sided. Now there are just 2 slots like the double-sided fork. Quickly just showing you. Is it clear? Clear? I put this at 0 and now you have 2 slots, upper lower. Just like how the double-sided was.
The single sided edible.
So this is a single-sided. I can share. So this is double-sided. 2 slots. So basically, if you have a single-sided and a protrusion gauge, you don't need double-sided. So you can use this as double-sided itself. So 2 slots. The lower slot is here. The upper slot is from the bifork. Okay. So first I'll explain this and then I'll show it to you. And again we bite into this, loosen this upper screw and take the jaw maximum protrusive, maximum reclusive. We want to know or calculate the range of motion. So when we take it maximum back, we get a value. Okay, so now it's close to -8. Okay, and we take it forward and it's around +2, +2, +3. Consider it is +2. Okay, don't think too much into it. The jaw is not going back by -8 because this lower side is not moving. Okay, so but to keep it very simple, just look at the gauge. When it is back, see how much minus, when it is front, how much plus. So now it is 10, right? Minus 8 to 0, 0 to plus 2 is 10 mm is the range of motion. So 50% of that range, 5 mm can be a starting point. So 5 mm from our minus 8 position will come to around minus 3. Okay? Is that clear?
For finding itself, we are bringing it to edge to edge position, right?
No, no. We are doing this when edge to edge is not tolerated by the patient.
The patient cannot do it themselves, we get it done with this.
No. When patient cannot tolerate edge to edge position. For edge to edge position, if patient can tolerate, you can start off with this. But if it's a class 2, patient may not be able to tolerate taking the jaw edge to edge. Okay, even if they do that, it will be too much of a pain for them. Definitely, normally when we take it to edge itself, there will be some kind of a muscle listen, that's normal. But if it's a class 2, it's very difficult for them. So, in that cases, we want when in cases where we want to record the bite at more than edge to edge or less than edge to edge is when we use this. So we find out the range of motion, maximum forward, maximum backward, and 50% of that range. Okay. So I keep this now on the gauge. There is a plus and a minus. Okay. So when we go back, the value comes in minus. Okay. When we go back, the value comes in minus, and when we go forward, the value comes in plus. So I will keep it at minus 3 if it's 5 mm, and when I keep it at minus 3, this is how it is. So it's not edge to edge. It's 3 millimeters to edge. And then we take the scan. Do you want me to repeat it once again? Is it clear?
Patient will be with a normal overjet like
Yeah.
minimal.
Yeah, but for the patient from the class 2, he's at 50% of that range. If the patient can tolerate 55%, you can keep it at 55% also. So basically, why we can't just arbitrarily ask now when with this bifork in the mouth, we don't know which the MIP is. It is not clear to us. So which is why we get the range of motion. How much the patient can take forward, how much the patient can take backward, and 50% is a good starting point. If the patient can tolerate 55%, perfectly okay. Why? Because this is our starting position and we have the provision with the help of bands to advance this position further on. Okay? Do you want me to show this with this gauge? Not required, right? So you just loosen this, then this will go freely. Ask the patient to go completely retrusal, ask the patient to go completely protrusal, and note the reading at each stage. If the patient is completely retrusal, notice the value. Completely protrusal, notice the value. Take 50%, keep it at that 50%, lock it. Ask the patient to bite. Ask the patient if the patient is feeling okay, good enough, scan. That is all. So that is the difference between the single-sided bifork and the double-sided bifork and the use of the gauge. So along with this, we send the scan is sent to Dencare. Info was when we did it before, you know, with the medical fraternity, that's when we use this, but you can just send the scan to Dencare. Now, there are some requirements that you need to send. We have soft bands and firm bands. So the color that you saw is soft band. I don't think we have the firm band here. It's dark blue in color. So if a patient is a bruxer, you can give the firm band. So you need to see which is the band that you require. 1. 2, you saw the valve, right? So the valve is, you have an option to start the treatment with the valve or start the treatment without the valve. Now the device per se is around, I think 14,700. It's now 14,750. 14,750 is the lab cost. The charges I'll come to. I'll explain the patient and how to, you know, how to explain it to them. And So the X-valve can be introduced later also. So that's part of the titration I'll explain. So, but as a requirement, whether you want the X-valve now or whether you want the X-valve later, because the X-valve is billed separately, so you need to mention that. Now, apart from this, very important thing is you need to take a photograph, must. So you need to take a photograph of the patient smiling with the right hand up, close up of the face. Some part of the hand has to be visible to know which is the side. Now, why we want this photograph is, if you don't send it initially, the case is going to be delayed until you send. When we design, if there is a cant or if there is a midline shift, we want to see the facial and the dental midline. And the right hand is for reference, which is the right side. So that's why we say, take a photo of the patient smiling and the right hand up. Sometimes you may forget and the patient will be sending a selfie. So when the patient sends a selfie, you need to know which is the right, because sometimes the selfie will mirror. So otherwise what will happen is this extension will come to one side. Okay, so which is why you need to send a photograph. So these are the things that you need. Now chair side, what we check for is one is the fit. So when we deliver the appliance, so we insert the upper and the lower, the patient bites onto it. All the videos are there on the net, so you can have a look at it. And ask the patient to advance the mandible to lock into the lower tray. So that's how you deliver it. In some patients, if they have feeling uncomfortable, what you can do is you can give just the upper tray first. Get them to wear it for a few days, get them to be used to it. Then you can attach the lower tray with the bands. Appliance and next. Okay. So the appliance must fit snugly. So the appliance must fit snug. Okay, if it is loose, either if you have these burners, if you do a lot of nylon dentures, you may have it in your practice. To what we use to tighten nylon, you can use that. It's a flameless torch. Or you can send it to the lab and tell them at these points it is loose. At certain points it is loose. Now once you deliver a patient, uses the patient keeps it away for like 15-20 days, definitely it will become a little loose. Okay? So that is also something you need to tell the patient. And yeah, so once we check for the snugness of the fit. Okay? And then we come to the titration. So what we do is we tell the patient that, okay, so sometimes different people will respond differently. Some people will have hypersalivation, a lot of saliva. For example, I had a little bit of saliva. So you speak to the side. Within 2 weeks it will resolve. Okay, some people will have a dry this thing, different presentation. So just tell the patient it's okay. Only one case I've seen of an allergy, that to a dentist. Usually it's very rare, but that's very, very rare. So for one patient, the patient has a nylon allergy basically. So for such patients, you can't do anything. But otherwise, the most common symptoms will be salivation, some stretching of the muscles. So all of these are normal. So first thing is, for 2 weeks you will wait. At least 1 week you will wait. Make sure the patient is wearing this. Okay? And then the band comes in different sizes. What is 19 written on this band? So it comes with the 19 size, and you have bands of different sizes from 13 to 21. Okay? This is the soft band that you saw. There is also a firm band. So, but at the bite that we registered, it will come with 19. So if the patient is wants a little more of improvement, you change this 19 to 18. So the 18 band will be slightly shorter than 19. Therefore, the mandible will slightly come forward. So you can incrementally advance, and obviously you need to make notes in your note sheet, your case sheet, and you can incrementally advance the mandible in like 2-week period. Okay, and make sure get how or evaluate the patient. So that is one way to titrate. And once a position, for example, a patient cannot protrude more than 17, patient cannot go any more than 17. Then you can introduce the valve. These valves that you saw, this is the X valve. So you introduce the valve is clipped on in the front here, and you start with the medium valve or the yellow colored valve. Then you wait, and if required you move to the high or come down to the low. Generally low, people start from medium and stay at medium. For example, for me, I have not advanced more than my H2, more than the H2H position. It's 19. I still use the 19, and I use the medium valve or the yellow valve. That's what I use. Now, otherwise, if you're not using the valve, incrementally advance and then later on incorporate the valve.